someone who says I get back pain on bending, that's a regular scenario. But this can really, put you off. And unfortunately, you cannot get put off because the sign of orthopedics or the symbol of orthopedics is the scoliotic tree. And actually, orthopedics means straight child. Orthos is straight and pedos is child. So there's scoliosis and orthopedics has been kind of married to each other from inception. Andre's diagram or the depiction of scoliosis 1743. Okay, so what I'm going to actually talk to you about is what we normally teach our postgraduates. So this talk is actually designed for orthopedic postgraduates. It's going to take you through clinical evaluation, but while doing that, we will talk about certain things that may interest you more than others. So if that is okay, and I'm going to try and make this interactive, so don't feel threatened if I just call out a name and ask you to say something, because it's just, to get your perspective. There's, like I said, there's nothing right or wrong. I just want to know what you feel about it. Okay, so I'm going to just call out people and ask them what they feel. So number one is that scoliosis is a lateral curvature of the spine. This definition is important because scoliosis actually is defined only in one plane, and one plane is the AP plane, or the what we call the coronal plane. And this deformity has to be more than 10 degrees. Now, right at this point, I want to tell you the kind of difference in thinking that you and we have. That a lot of times, with no true curvature or a curvature of less than 10 degrees, which is sometimes just postural on an X-ray, some of our physios have labeled the person as scoliosis, and they come back saying that I've been told I've got scoliosis. On another count, like today I had a message from a friend's sister who said that my physio said I've got scoliosis because my right side foot is bigger than the left side foot, and I feel my left shoulder is higher than the right. So again, this may be right, but the definition still is that you have to have an X-ray which shows a 10-degree plus curvature. So be careful when you label someone scoliosis. If you call it scoliosis, you can call it a deformity. I'll tell you what happens is that if this thing comes out and say Dr. XYZ or physio told me that I've got scoliosis, and in the end there's no scoliosis, then that Dr. XYZ's name gets blacklisted in the orthopedic community. Not that XYZ cares, but now we are going forward thinking that, you want to be in unison, then you got to speak the same language. So that's the only point I'm trying to make. So it's important that you don't label scoliosis just randomly out of the top of your hat. Okay. Now the second point is here, that we feel that scoliosis is just a one plane deformity. So I'm going to now ask Mehika. Okay, Mehika, this girl in the center, do you think she has kyphoscoliosis? Would you say that? The picture in the center.
So according to this view, yes.
Right. Anyone disagrees? Right. So that answer is predictable, and that's again a catch question we ask our PGs, and everyone says what you said, that this is actually kyphoscoliosis, when the truth is that I would say 90% of scoliosis are lordoscoliosis, and what appears here as a kyphos is actually a rib hump. So you'll know this in the next few slides, that we see scoliosis as a one plane deformity. And if someone like me puts the question, you try to feel the back and say, oh, this looks rounded, so it is kyphosis. But in reality, scoliosis is a three-dimensional deformity. So this is kind of shaking your basics up, but it is the truth, and you still, you need to know. So in the sagittal plane, this is usually a hypokyphosis. So I'll explain you how that goes. In reality, scoliosis is a rotational deformity. I'm going to ask you to look at this photo here. This stack of coins that are kept on each other. So think of your spine, or look at the axial view, looking down the vertebral column, and the bones are kept one on top of the other like a set of carom coins. And you start twisting these carom coins right in the center, and that's where scoliosis starts. So the genesis of scoliosis is actually a rotation at the apex. This rotation, as you can imagine, is not in the central axis. So in the carom coin, there's a central axis. If you just move the coin around that axis, there will be no deformity. But this is around an eccentric axis, so the carom coin spins outwards. This outward spin gives you the effect of a lateral curve on an AP view. And in reality, so now I am the vertebra. I'm sure all of you can see me. I'm the vertebral body. These are the two transverse processes. When I spin out, see what happens to me. I actually get pushed in the front. The vertebral body gets pushed in the front, and the transverse process gets pushed out. Along with that, the ribs get pushed out, and hence that appears like a bump outside, but the body actually is gone up in the front. I hope that is clear. So actually this curvature is a lordotic. It actually reduces the kyphosis of the spine. The vertebral body gets pushed out into the concavity, the convexity gets pulled out, and the ribs come out. And that is now this photo here on the bottom right will depict exactly what I'm trying to say. You'll spend a few seconds looking at it, so you'll know. Even there's a 3D CT, which is also trying to show you what I said. The way to know this, it's important to know if your child actually has a kyphosis, because kyphosis and scoliosis is a red flag. So anyone who has kyphoscoliosis is a red flag kid. He's going to, have a big problem. He's either neuromuscular or he's congenital, or he has a, tethering inside. There's something bad happening inside, maybe neurofibroma. Most scoliosis are lordoscoliosis. So the way to know is that you take your thumb and push it down the middle of the spinous processes. So don't look at this apparent bump, but run your thumb along the center of the spine, and you'll see that it gets pushed inwards rather than outwards. That is one way of knowing. Otherwise, there's something called Stagnara view. So when we take an AP view in scoliosis, that AP view is actually oblique because the bone now is twisted. So if you can take and put the X-ray plate in the direction of this obliquity like this, you will get a true AP view, and that will actually show you that this is, that AP and that lateral view will show you that this is actually a lordosis. Am I clear? Any questions on this concept? Because this concept is very basic, and if you miss on this concept, then things can go downhill from there. Anyone wants to ask anything, or is it clear? Do you want me to repeat this? All right. So as far as you're concerned, desist from the temptation of writing kyphoscoliosis for all the scoliosis patients you see. Let your default setting be lordoscoliosis, and you really spend time understanding if it's kyphosis, and only then write kyphosis. Because anyone who mentions the word kyphoscoliosis and refers as the patient, so we think ye MD medicine hoga, ye gynac hoga. And clearly, orthopedic physical therapists are far better, and they understand far more than gynacs and MD medicine, right? So you don't want to casually mention kyphoscoliosis. Just call it lordoscoliosis. Manjot wants to know Stagnara view, so I'll just go back one slide. And if you see this photo here at the bottom, you will see how the spine is rotated. Or look at this picture. You will see that the spine is an oblique plane. When you look at the person from the back, the back is not looking at you like this. The back is looking at you at an angle. If I keep the X-ray film straight, I'm getting an angle view of the back. So if I keep the X-ray view parallel to the spine, to the plane of the spine, because the spine is like this, not like this. I need to keep the X-ray view in that fashion. I get a Stagnara AP, and that's called a true AP in a scoliosis. So typically, good radiographers know what's a Stagnara view. So if you just mention Stagnara view, that's fine. Stagnara was actually a big guy in scoliosis. He's the guy who also described the wake-up test in scoliosis. So that's the Stagnara view anyway. I hope that's clear. Otherwise, ask me again. I'm just moving on because there might be a delay between you asking and me going forward. Now, there's another concept that you need to know, and the next few slides actually will just, will be covered in just one, this concept. So there's a concept of structural curve and non-structural curve. So again, I want to give you an example which you will never forget. That just imagine that in your class, in a class in school, there's one bad guy, and he's a really nasty guy, and his character is bad, and he is going to spoil the guys who sit around him. All right. Now, if I as a teacher want to run the class well, I want to get that bad guy out first. If he's out, then all the remaining 99 students will be able to study well, and they will not get spoiled. Okay. Now that's the same concept in scoliosis, that of the 33 vertebrae, one vertebra is the bad guy, and he starts spinning first. Now, we are unable to pick that out because that's a very subtle spin. So along with that one, two others start to spin, and then two others start to spin. And eventually, there's a gang of 6 or 7 vertebrae which have got converted to a rotated apex of the scoliosis. Okay. Now, these become the bad guy gang. Okay. Now, along with this, so if you see a C-shaped curve, you will have the top 5 or 6 vertebrae, which are the bad boy gang, which means they can't be changed. There's no way that you can correct them. The sooner you fuse them, the less the effect on the rest of the spine. But because these are spinning out, even these on the top and at the bottom will start curving because they are kind of curving into the curve. So the part which is the which is the bad guy, which can't be corrected. There are certain characteristics of that, is called the structural curve. So the structural curve is really the part of the scoliosis which will not correct whether you bend, whether you give traction. It will not correct. This is typified by intrinsic changes. Because scoliosis happens over decades. There's a bone formation change, like a bone shape change. There's a rotation element. So if there's a rotation, there's a change in the shape of the bone. The bone may look triangular. And as far as you and me are concerned, when you do a full bending X-ray on one on the other side, you will see that this one does not budge. The rest of the spine opens up, but this part doesn't budge. This is the structural curve of the spine. And leave alone physio, even surgical maneuvers can't actually correct that. So when you talk of correction of scoliosis, we are working on the not so bad guys who are in bad company. We work on them. So if you see this picture here, I'm going to say just arbitrarily that these three or these four bones are the structural curve. And these are the curves that are secondary, or the bones that have formed the secondary curvature, or they have kind of joined this gang. They're getting forced to join this gang. So when I do correction, I'll align these because they are still correctable. But this may not get corrected unless I do hard bony work, like I chop the bone, fix the bone again, etc. Another concept is that this entire curve then gets labeled as a structural curve because this curve has the structural bones in it. But you will see that there are two more curves. There's one at the bottom and one at the top, which become the non-structural curves, because these two curves are there because that structural curve is there. So if once I start getting a bend in the middle of my back wants to balance itself on the top and at the bottom. The back is a mobile unit. It's not a fixed bone. So that those balancing curves, which are actually flexible, and they would have not existed if there was no primary curve or no structural curve, are called the non-structural curves. Are you able to understand this concept? Otherwise, again, ask me. You can actually unmute and just talk instead of chatting, putting it on the chat box. Just unmute and talk because it's an open house.
Yes, sir.
Okay, so just to again kind of wind this up again, scoliosis starts at one place. That one place which has been there for many more years than the other bones, that becomes a structural element of the curve, which is an immobile element, which on lateral bending will not change its angle. There are other bones that fall into the same curve, and they're the correctable part of the of that curve. And there are two curves, one on the top and one at the bottom, which try to balance the spine in general. And these are called the non-structural or the compensatory curves. They're trying to compensate for the bend in the back. How will you know that they're compensatory? When you do lateral bending X-rays, you will see that they are able to correct. So they don't have intrinsic or inherent changes in them. They are just placed awkwardly because they want to balance the spine, balance the S. All right. Okay, I'm assuming that's clear. So now this is important because of this concept called the decompensated curve, and you all need to know what that is. So actually today, it's all about balance. So when we talk of treating scoliosis, we actually know that we can't make a curve into 0 degrees, no matter what we do. So if we are able to get a balanced spine and a mobile spine, so if the goals of scoliosis correction are to get a balanced, mobile and functional spine. In the past, it used to be to correct the angle of scoliosis. Today, that's not the goal. So balance is inherently related to gravity. If the line of gravity goes from the top to the bottom, so C7 plumb line goes into the gluteal cleft, you're balanced. No matter how many S's are there in the middle, you're balanced. If you're imbalanced, so like in this picture, you see the plumb line or the gravity line that's drawn from C7, vertebra prominence, drops off-centric to the gluteal cleft. That means somewhere down, the curves don't add up. Finally, one curve is winning against the other curves, and hence the body is going off gravity. This is called decompensation. The decompensated curve is a red flag. So even if it's a 20-degree curve, but it's decompensated, it's a red flag because apart from growth, gravity is contributing to its worsening. So by mere existence, by merely being vertical, the chap is going to keep getting worse. Is that very clear? So you have to look for decompensation. Decompensation is clearly when the head shifts off or the shoulders are off from the pelvis or the center of gravity is off. And it's very easy to do this check in your clinic. You just have to take a rope and tie any weight at the end of it and you'll see where it falls. So a decompensated curve is far worse than a high magnitude curve because you've got two enemies now. So here's an example. The girl on the left is a very high degree curve, but it's compensated. So here progress will happen mainly by growth. While the girl in the central picture, the angle of the curve may not be that high, but because she's decompensated, she's going to rapidly fall off. All right. Now, the relevance of this to physical therapists is that it is there is a huge scope for y'all in this central picture compared to the picture on the left. So in the central picture, if you can work hard on these, on these muscles here to try and pull the bone back or pull the spinal column back, you may compensate a decompensated curve, which will be a huge clinical benefit. While here, there's not as much that you can do because here, whatever you do will have to actually pull the curve up. And that's not easy through, through muscle balance. While here, a muscle balance can actually, in the side view or in the lateral plane, it's easier to pull the spine back rather than to get a spine vertically, tractioned by strengthening muscles. Do you agree? Any difference in opinion? Jinali, Mihika, Sukanya, anyone?
No, sir, we agree.
Yes, sir.
You don't have to say yes. If you disagree, it'll be more fun. Chalega. So I hope that's okay. Now I would also get to you, see these definitions are not critical for your practice, but you need to still know this because once again, when we are talking of speaking a common language and for a better understanding of scoliosis. So as soon as we are done with these definitions of what we call strategic vertebrae, so you will kind of be able to, the next time you see a scoliosis, you will see it in a very different light. Okay. So strategic vertebrae are vertebrae that make the deformity, and there's only one way that I can show you this. So when you see India's cricket team, there are 11 players there who are playing, but the guys that you look out for is, are the main guys in there, right? The guys who make the difference, those are the guys you look out for. So those are the guys who make or break the team. If they do well, the team will do well. So if I can tackle these bones well, I'll be able to tackle the curve well. And that is the end vertebra, the apical vertebra, the stable vertebra and the neutral vertebra. Okay, so we'll try and define these. Vishakha, do you have a question?
Yes, sir. Sir, I just wanted to ask you what decides the difference between the decompensation and compensated spine? Like how it varies? Like what
So
decides the
clinically
difference?
and radiologically, if you, the vertebra prominence, the C7
Yeah.
spinous process, that has to be in the straight line of gravity as the natal cleft, the gluteal.
Yeah.
So if at the end of whatever it is, if that is off-centric, means if you draw a
Yeah.
straight line vertically down from C7, it's going off from the gluteal cleft. That means the spine is unbalanced, which in scoliosis term is called decompensated.
Okay.
In on a radiograph, or what actually happens inside is that if you see this picture on your right, there's a curve in the middle, but there are two curves at the bottom, at the top, one at the top, one at the bottom, which is trying to balance this S. If there was only one curve, the spine would have gone off there. So when I start getting a scoliosis, this is what happens. But because the body has a righting reflex, the body does this and that at the bottom, at the top, which are the flexible parts of the spine, to try and get it back in line to balance itself. The body has a natural reflex to balance. So the curves at the bottom and at the top of your main curve compensate for this curve. For example, if this angle is 40 degrees,
yes,
the addition of 1 and 2 is 40 degrees, then you will have a straight spine at the end. There will be a curve, but the line of gravity will be straight. So when they don't add up, for example, if this is like 100 degrees, it's difficult for the lumbar spine to compensate by 100 degrees. So it ends up decompensated. So on a radiology, or what happens inside is the addition of the upper and or lower curve does not add up to the magnitude of the main curve. And that's why you get a decompensation.
Sir, is it that the decompensation later can cause the compensated spine, like it goes progressing that way, or there is a by the reason actually the differentiation has been created?
Yeah, so normally scoliosis worsens with growth. Scoliosis is a deformity of growth, and traditionally once growth is complete, scoliosis progression stops. We'll talk about that a little later. But traditionally, that's what happens, which is why scoliosis rapidly rises during the growth spurts. So most people come in adolescence. Okay.
Okay.
But if it's a decompensated scoliosis, gravity will keep pulling it out. So like the leaning tower of Pisa, no matter what you do, it's going to continue to lean because the center of gravity is off. So
Okay.
no matter what happens, even if growth stops, a decompensated scoliosis will keep worsening. So at any point in a decompensated scoliosis, there are two worsening factors, growth and gravity. While in a compensated scoliosis, there's only growth. So a decompensated scoliosis worsens much more rapidly than a compensated scoliosis. And that's why it's a red flag.
Okay. Thank you,
And
sir.
again, Manjot has asked, is it a red flag to examination or to surgery? So it's a red flag to the condition, Manjot. So if just what I said right now, if you get a decompensated scoliosis, it's going to rapidly worsen and you need to do something soon. If it's a compensated scoliosis, you can say, take opinions, spend 6 months working it up. But in the decompensated scoliosis, in 6 months, the angle may increase by 10, 12 degrees straight away. So it's not a red flag. It's a examination red flag. I hope that's clear. Any other questions? You can still keep asking while we speak because there's a time frame we want to finish this in, but I'm more than happy to come back and answer questions. We don't have to finish this talk at all. So once you understand the concept of end vertebra, apical vertebra, stable vertebra, neutral vertebra, things will get again more clear. So end vertebrae are the I think the screen is coming in the way, are the two maximally tilted vertebrae at the end of the curve, which is these. Okay. So end vertebra refers to the tilt. So whenever you see, this is important because when you measure the curve, you draw a line that's that's parallel to the upper end vertebra and the lower end vertebra, and that angle gives you the measurement of the curve. And I think all of you all should be able to measure the curve in scoliosis. So this is done in a standing AP X-ray. It can't be done in a lying down X-ray. So that's rule number one. Whenever a girl comes to you and you suspect scoliosis, do not ask for an X-ray unless you know exactly which X-ray to ask for. And the X-ray to ask for is a whole spine, 36-inch film, big plate. You can just write big plate, TL spine from C7 to S1, AP standing. That's the only X-ray that you want. All the other X-rays will be needed by the surgeon when he wants to do surgery. If you do this X-ray lying down, or if you do the X-ray that does not cover the whole spine, done on a small plate, you will have done major disservice because these girls continuously get X-rays because then she'll go to the next therapist, then she'll go to your senior will ask for a bigger picture, then she'll go to the surgeon, he'll ask for 6 more X-rays. So at the end of the day, these adolescent girls burn their breast tissue and their gonads, and that's a major problem. So you're committing a sin if you ask for an X-ray irresponsibly. So always ask for a full spine 36-inch plate covering T1 to S1. Let them figure out how. The radiographer may call you and say, "Hamare paas nahi hai, fuck off, go somewhere else and do it." But do it in the right way because you don't want to burn the child's gonads. Okay. So a large plate covering the entire spine and standing, because there's a sea of difference between a standing X-ray and a lying down X-ray. Is that clear? So in a standing X-ray, the most tilted bone on either end of the curve becomes the end vertebra, the upper and the lower end vertebra. So it's reasonable to say that every curve has two end vertebrae, one upper and one lower. Now in this curve, can someone, I'm losing the names because Kajal, can you, sorry, you're up in the front. Can you tell me which you think is the upper end vertebra here and which you think is the lower end vertebra in this curve?
I think in this, the lower end will be L4 and the upper one would be T8 or T7.
Okay, so thank you for the answer because you're by and large right, but I want to make one correction. That at this point, I want to introduce to you a principle that we as surgeons also learned only 20 years ago. That any spine you see has 3 curves, full stop, dubara mat puchna. It may look like a C, but all have 3 curves. So once you start looking at it like this spine where you would have otherwise thought, or what I would have thought 20 years ago, has a right convex thoracic curve, actually also has a left convex upper thoracic curve and another left convex thoracolumbar or lumbar curve. Is that clear? So from now on, any scoliosis X-ray you see, one curve may take your attention away, but do look above and below and you'll see small fractional or full curves at both ends. So divide every spine into 3 parts and now define 3 different curves independently. Okay, which means that when I ask you, Kajal, can you tell me the end vertebra for this scoliosis? Your immediate question should be, sir, for which of the 3 curves do you want the end vertebra? Okay, so this is again a trick question we ask in PG exams. If they just give me the end vertebrae, I'm saying, oh gosh, but I wanted for the upper curve, for the cervicothoracic curve. Got it? So your upper end vertebra was absolutely right, but your lower end vertebra was correct for the lower curve. So if we just talk of the thoracic curve, or we call this the main thoracic curve. So it's divided as proximal thoracic, main thoracic, and thoracolumbar. That's how the nomenclature goes. You need not follow this nomenclature, but for the main curve, you will see the most tilted upper vertebra, as you rightly said, is T8. This is most tilted into this C, because this is now tilting into that side. But as you come down, L1 seems to be most tilted into this C, while L4 becomes the lower end vertebra for this curve. If you now just put your attention on where my cursor is, this is another standalone independent curve on the opposite direction of the main curve. So there's no way you can make that mistake. This is not going down like that. It's going into the opposite direction. And the fact that it's in the opposite direction, so let me try and annotate you, or am I clear? Otherwise, I don't know how to.
Yes,
sir.
This curve is like this. This curve is like this. They are in two different directions, and that curve is like this. Okay. So once you know that, it becomes easy for you to decide which curves you want to look for and call their end vertebrae. Is that very clear? Any questions?
Hello.
Yes.
My question is, in the same X-ray, can you tell which is the structural, non-structural, and compensatory part?
So the obvious answer would be that this is the structural curve, which we are calling the main thoracic curve. Your immediate question will be why, and why not the others? So there are 2 or 3 reasons which I'm going to depict. One is that in magnitude, this seems like the most, the most curved part of the spine compared to if you just fix your eyes on this, you'll see how light this curve is or how gentle this curve is, but this looks quite, so magnitude wise, it's the most, number one. Number two, if you see rotation, and I'm going to later show you how you can identify rotation, but while we're at it, I may show you over here. Can you just focus on this bone, this what we are calling L2? You will see this is the spinous process of the vertebra. Just imagine the vertebra model that you have in your eye, in front of your eyes. That is the vertebral body, the rectangle. This is the transverse process. And can you see these 2 eyes? If you look at this, they're the 2 eyes of the face. They're the pedicles. Now, in a normal spine, so if you take my X-ray or your X-ray, all your bones will have the nose or the spinous process in the middle of the eyes, centrally located. If the nose is eccentric, so you look at L1, you'll see the nose looks more on that side than this side. Again, if this is the eyes, the nose is looking that side. It means this bone is rotated. If I go higher up, you'll see the nose is much closer to this side than that side, etc. Okay, when you go lower down, you see here the nose is closer to this side than that side. So when the nose is central, the bone is not rotated. The more eccentric the nose, the more the rotation, because the spinous process has actually tilted. So if you look at my face, this is my spinous process, these are the pedicles, and these are the transverse processes. As I start rotating, my nose will go towards the convex side, and my one eye will look bigger to you, the other eye will look smaller. Similarly, the pedicles start looking eccentric. You see this pedicle looks round and nice, but this one looks like a slit. Right? So the one that's round is on the convex side because that's where the bone is rotated, just like this. Is that clear? So that's the second reason why there's so much rotation seen here. The angle is very high, and this clearly is the major deforming force in this curve. So this is structural curve. However, I can only define structurality if I get a bending X-ray. So I may be surprised that if I do a right bending X-ray and the angle from 74 becomes 0, this is no longer structural curve. Am I kind of getting through? Or is it confusing?
Yes, sir. Yes, sir. Clear.
Yeah, clear.
Right, superb. So if you're not able to define which is the most tilted bone, you can draw lines along the end plates, and you will see that the lines open up, then they become parallel and they start closing down. So when I'm only looking at this curve, when the line opens up, it means the lower bone is more tilted than the upper bone. Try to think about that for a second. If the lines are parallel, it means that this bone and this bone are equally tilted. And if the lines close down, it means this bone is clearly more tilted than this bone. Oh, sorry, less tilted than this bone. Okay, which means that in this scenario, L1 and L2 are equally tilted into this curve, So they both become candidates for my lower end vertebra, in which case the one that's closer to the curve becomes the end vertebra. Okay, so here, as per this depiction, L1 is equally tilted as L2 because the line between them is parallel, this space is parallel. So by nomenclature, L1 gets the name of lower end vertebra. Similarly, if you see above, you may argue that T8 and T7 look equally tilted to your eyes. Then you still call T8 the upper end vertebra because that's closer to the curve. Okay, it's not that critical for you to differentiate, but as long as you don't call this the end vertebra or L4 the end vertebra, you're fine. Okay. Is that okay? Most radiologists also get it wrong. A lot of PG students get it wrong. So Shikha is asking which side is right. By convention, any scoliosis X-ray is seen as a posterior anterior view. So you're looking at a child as you see her in the clinic. One way to know is the heart. The heart is always on the left. So you're always seeing right to right, left to left. Unlike chest X-rays, which is exactly the opposite. So by convention, in scoliosis, there are PA views, and you put the X-ray in a way that the heart is on the left. So you know on your right is the right, and on your left is the left. Otherwise, there's major confusion. I hope that's clear also. Okay, so that's how you measure angles. And once these end vertebrae are fixed, they remain fixed forever. And for any in any kind of a X-ray you do here onwards, the end vertebra for the main thoracic curve will remain T8 and L1. Okay, I'm saying this because now, sorry, this keeps jumping up and down. But when I do a bending X-ray, so today, it's a norm to do bending X-rays on all scoliosis cases. Okay, for two reasons. One is you want to see the flexibility of the curve, and the other you want to see the ability for the spine to balance back. Okay, so in this kid, I will ask for a I'll ask for a right bending X-ray. That right bending will tell me how flexible or how correctable this one is, this curve is. I'll also ask for a left bending X-ray to see how, so if I draw a straight line, it's going slightly off-centric. I want to see when the child bends here, does that line come in the center? So I want to see the flexibility of this X-ray, of this curve, sorry. So in any scoliosis, I'll look at both bending X-rays, which are done lying down. We'll talk about that later. So when we talk of X-rays, we spoke of a large film AP standing view, and we then speak of left and right maximum bending supine views. So the bending views are always done supine. The reason being that when you're standing, gravity tends to telescope the spine. So there's, as you can see in this X-ray, abutment of the rib with the ilium, which makes the X-ray insufficiently bending. The child will be able to bend more, but the ribs are stopping him from bending. And the muscles are active. When you're standing, it's an active bending. So the muscles hold you back. They don't allow free bending. So when you're supine, both these, the gravity is eliminated and muscle power is eliminated. And hence all bending X-rays are done supine. I hope that's clear. Now, when this child bends to the right side, you will see a part of the spine. You will see now the new end vertebrae here have become, the lower end vertebra from L1 has become T12, which means that L1 is the non-structural part of this curve. And the part that did not move even on bending is called a stiff segment. It's not so important for you. All I'm saying is that don't label end vertebrae on bending X-rays. Label them on standing AP X-rays only. Is that clear? A bending X-ray will tell you which part of this curve. So arguably this curve starts from T8 and ends at L1. But on bending, you will see L1 is correcting itself. So it is that kid who's in bad Sangati, but he is happy to become normal if you get the other kids normal. So which means that when I work as a surgeon or you as a physical therapist, this is the enemy number one. This part of the curve or this segment of the curve has to be worked on hardest. T8 and L1 were actually just being dragged into the curve when they don't want to get into the curve. I hope that's clear. Any questions? So this X-ray will depict how you look at, so there will be a third set of angle here also. Always look at one curve, another curve, and a third curve. That will at least give you a perspective of balance, a perspective of which to treat. Because when you treat, you honestly are going to be treating this curve and that curve because you can't do squat about this curve. So work hard on these curves to get the balance right. Am I getting across? Any questions?
So please repeat this.
So typically the structural part of the curve, which is the fixed deformed part of a scoliosis. The scoliosis now, just to sum up, any scoliosis has three curves. It's a triple S, not a regular. A regular S is a double S. So a scoliosis is a triple S. invariably in this triple S, one or two curves are stiff. A stiff curve is very difficult to correct through bracing, physical therapy, even surgery. It's very hard to correct. So when we correct as surgeons or when you correct as physical therapists, you have to cash in on the flexible part of these curves and on the third or the one or two curves that are flexible, which are the non-structural curves. Because correcting that will actually give you a cosmetic improvement. If you spend time trying to correct the structural part, it's like hitting against a wall. You will not get any correction. Is that getting through?
Yes, sir.
So maybe if we complete this lecture today, you'll see towards the end that when we do surgery also, we know that it's very hard to correct this. It's very fixed and rigid. And to correct this, you have to do osteotomies, which are quite dangerous to the nerve, to the spinal cord. And hence we will use the bending X-ray, as you saw over here, to see, okay, in this part, I don't have a good bang for buck, which means I'll have to work too hard to get a little bit. But in this part, I can really work hard to get the spine straight. Okay, so I will do more maneuvers in the upper and lower part and not spend too much effort on the stiff part. And that's what you will do also. So for example, in this child, if she comes to you and you're asked to do physical therapy for this child, your best bet will be to work on the abdomen, to work on the trunk rather than the chest. Though you will work on the chest, your best bet is the abdominal muscles for two reasons. One is it's a flexible part of the scoliosis, and the second is that anyway the lumbar spine is the flexible part of the spine. If your column is flexible, there's a scope that muscle strengthening will make a difference to the column. If the column is rigid, there's a very little scope that muscle strengthening will actually make a difference to the column. Okay, so to get a thoracic scoliosis corrected through muscle strengthening is really a utopian dream, because the thoracic scoliosis is not only the spine, but it's bound by the ribs and then the sternum. So it's like locked in. No matter how the muscles work, it's very difficult to actually correct it. While in the cervical and the lumbar spine, it's a free rotating column which has been bent. So if you push the muscles, they will be able to control the column much better, because there's no ribs and there's no sternum and there's no clavicle there. Okay. So again, you'll see here. So if through your physical therapy, you could get this curve to look like that, you'll have done a great favor to the kid, right? Is this getting clearer now, or is it still difficult? I don't want to get more confused. I'm just trying to give you more ideas. Bending X-ray is taken in bending forwards or sideways, always sideways. Bending X-ray so scoliosis, though we mentioned it's a three-dimensional deformity, we address it as a coronal plane deformity. So any bending X-ray is done in the left bending and the right bending only. There's no forward and backward bending, which you would do in a spondylolisthesis, which is a sagittal plane deformity. Okay. Now, why should it be done supine? Because if you do a standing AP X-ray, the muscles are active when you stand, and hence the bending will get restricted. While when you're lying down, the muscles are switched off, your bending will be much more. So if you're able to bend more, the correction ability of the bending will be depicted much better. I hope that's clear, Bhagyesh. Okay. Okay, now what is the apical vertebra? It's the most rotated vertebra at the center of the apex. So typically it's a colloquial English language word. So what is the apex of this curve? Somewhere here, isn't it? What's the apex of this curve? Somewhere here, isn't it? What's the apex of this curve? Somewhere here. So you've got to see it as 3 C's. And if you look at it as 3 C's, so again, I'm going to use the annotation here just to, give you a general sense. So that curve I'm drawing here. Okay. So as far as you're concerned, you will only think this as the curve, right? But I have now told you that you have to look at this as one curve, this as one curve, and this as one curve. That's true for any spine. Okay. Now, if I want to see what is the end vertebra, apical vertebra of this curve, I have to put my head in an angle which makes me look at this as a C. I will know, okay, this is the upper end vertebra, this is the lower end vertebra, and this seems like the apex. Now the same thing over here, now that I've excluded all the others, I'm just looking at this, I will know, oh, now this curve, this is the upper end vertebra, this is the lower end vertebra, and this looks like the apex. Similarly here, this will be upper, this will be lower, and this will be apex. But if you look at it as a general curve, it will be very hard for you to actually make out this curve and that curve. Am I coming across?
Yes, sir.
Yeah.
Yes.
So you have to focus in, zoom in on that part of the spine, and the curve will start appearing to you. If you look at the whole spine in general, that curve will disappear and you will not be able to identify what is the upper curve and what's the lower curve. Okay. Oops, now I'm not able to get this annotation out. Escape. Oops. Okay, there you go. Okay. Okay, so the apex is the most deformed but least tilted apex of the curve. This is important because the apex of the curve is that bad boy who started the problem, and you need to identify the bad boy because at least that guy you need to get into the into your fusion. Is it apical vertebrae will be mostly center of the two end vertebrae? Yeah, more or less yes. That the apical vertebra are normally equidistant from the upper and lower end vertebrae. Which also I'm expecting the next question from you, Shikha, is that sometimes it can be a disc. It need not be a bone. So sometimes you may have 3 bones on top and 3 bones at the bottom, which means the apex becomes a disc. Okay. Again, this is going into semantics and technical details. You need not know. It's just a concept that you may be, you may want to be aware of. All right. I'm going to now, any questions? Just ruminate over this while I clear the annotations.
Sir, how much does the lateral bending X-ray films translate into clinical practice? That I know this is now non-structural and I can work into it.
Yeah, so a very, very good question. And it's a question that all of us feel challenged with. That why do we do bending films to begin with? We do bending films to decide how much that curve is correctable and what is the flexible part of that curve. Now, the best way to actually make that curve corrected is to put the patient under anesthesia, dissect all the muscles off, and use some hard force to correct it, which is surgery, right? In surgery, you give anesthesia, so the muscles are totally relaxed. You take away all the attachments of the muscles, so there is no control over the muscles over the spine. And then you use maneuvers, rods, screws, the entire lohar chal is brought there to correct the spine. Now, this is done in surgery, but without surgery, how close can we get to that correction capacity? That's the crux of the question you asked. So the best X-ray to be done is an X-ray that's done under anesthesia with traction and bending. Okay. Now this will give you the closest to surgical correction. Like if you are going to get a 40-degree curve corrected to 20 degrees by surgery, this kind of an X-ray done under anesthesia with traction and with bending will give you like closest to that 20 degrees, maybe whatever, 30 degrees, 25 degrees. The next best is a supine bending X-ray, and the next best is a standing bending X-ray. So the more hard work you do on the X-ray, the closer it will get to showing the flexibility. Does that answer your question? Who asked that question?
Yeah, I asked it, sir. Manjot here.
Manjot. So is it answering your question? So when I do say a left bending X-ray here to see what's the correctability of this curve. If I put this child under anesthesia, okay, and then I gave traction. So one of my registrars is pulling from the top, one guy is pulling from the bottom. And then I put some fulcrum over here, like a pillow or a rolled towel. And then I bent forcefully using my hands. That is the best way to know how flexible this is. But it's impractical to do that. So we just do a supine bending X-ray. Okay. But sometimes we do this X-ray. It's called a fulcrum bending X-ray under anesthesia when we are really stressed about how much to fuse. Is that okay?
Yes, sir, that's absolutely fine. I'm a physiotherapist, so basically we get an X-ray. We don't get these details. How was the X-ray done? So we just get an X-ray and a report, and we have to conclude how much to apply force on the patient. So that's what I'm asking basically.
So just purely from your perspective, you would be most interested in the flexibility of the lumbar spine. I mean, that really sums it up. So the drawbacks to your assessment would be that if this X-ray was done standing bending, you may not get a realistic image of how much the lumbar spine is bending. And number two, which I want all of you all to keep your eyes open for, is that if a bending X-ray, you see what is called costopelvic impingement. So I'll just show you that in one of the, like here. So here, you say this one, this is the X-ray that you're trying to look for. You see that there's a costopelvic impingement happening, which means that this X-ray is not doing enough. There could be much more flexibility than this X-ray suggests. Okay. So these are the two hindrances. One is gravity, so standing X-ray, and one is costopelvic impingement. These are the two hindrances to actually telling you how flexible your lumbar spine is. I hope that's clear.
Yes, sir. Thanks.
Right. So neutral vertebra is about rotation. I will quickly tell you about that rotation because this is something you all should know. Because once the bone starts rotating, a mere coronal plane correction through physical therapy is not going to be enough. And all bones don't rotate. Only the real bad boys in the class, the top apex and its few vertebrae around it are rotated. All the others are not rotated. It's important to know which is not rotated, because once it is not rotated, it's still in your side. You're still able to maneuver it through your therapy or through anything else. Okay. So how do we clinically know how the curve is stiff? It's generally difficult, but when you eyeball a curve, so maybe we'll see some of the, you'll see how the curve looks, and you have a general assessment, and you say, okay, this curve looks like 30 degrees, or you make any ballpark figure that is true to you. When you ask this child to bend on one side, now, unfortunately, we do this bending in a standing position. Ideally, you should lay the child prone and ask him to bend on, or ask her to bend on one side. You will actually on the feel see how much this curve is opening up. Okay. Ideally, any curve should be 50% flexible. Again, this is so relative, it's so subjective that if I'm calling this 30, you may call it 50. But it doesn't matter. You will be able to generally judge that is this moving at least by half its degrees, or it is not moving at all. So the child looks like this on prone bending on your couch. You put the child prone and ask the child to bend on the right side. And you see that on bending, this is happening, or this is happening. This is a rigid curve. But if this happens, it's a flexible curve. Now this rigid and flexible is a colloquial subjective word. It is not an objective tight word, but you're free to say rigid or, if it's rigid or not. Again, the clue is that normally the main structural curve is the rigid one, and the compensatory curves at the bottom and top are normally the flexible ones. Generally, the thoracic curves are rigid because they're bound by the ribs. The lumbar and the upper thoracic are normally not rigid. I mean, that's the best I can answer this question. Okay. So this is the depiction of rotation that I was trying to give you, that when you look at any bone, you look at it like the face of an owl. The pedicles have to be equidistant from the middle, and the midline should belong to the spinous process. As the bone starts to turn, so it invariably turns towards the convex side. So here the right is the convex. The more it turns, the bigger the pedicle on that side starts to appear, and the smaller the other pedicle starts to appear, till the point that the one side pedicle is totally lost, and you see only one pedicle. This is actually looking at a side view. It's almost like you're seeing the side view of a person. And this is max. So these are the grades of rotation. Again, you need not know. You just need to know whether it's rotated or not. Here, this X-ray is very clear that there's a rotation, because you see the spinous process, the lamina, the pedicles. You clearly see the spinous process eccentric, much closer to this side. So this is the concave side. This is the convex side of the scoliosis. I hope that's clear. This is the classic non-rotated vertebra, where the spinous process is right in the middle of both the pedicles. Is that clear?
Yes.
This is important because any correction that you want to give, so let's say that you have the magic in your hands to actually correct a scoliosis. You got to correct it in the line of deformity. That's the basic rule of correction. So the bone that is not rotated is bent only in one plane. So you just have to give a coronal plane correction. A bone that is rotated, you need to give a 3D correction, a push prone kind of a correction. Otherwise, it's not going to correct. So if you if you try to push a rotated bone in a coronal plane, it will hold back. It will be rigid. So if you are making a brace, for example, for a child, remember the 3-point brace, the middle point is actually posterior. It's not lateral. So it's trying to unrotate the rotated apex. While at the bottom and top is just doing that. It's just trying to correct the coronal plane. But at the apex, it's trying to push the apex down, because it's trying to derotate the apex. And that's how you should be thinking also. So any maneuver you do should go against the basic deformity. And if the basic deformity is rotation, just a lateral correction is not going to be enough. I hope that's clear. Okay. Stable zone is not that important to you, but just like the stable line that we spoke of, or the plumb line, a stable zone is more like an area which goes around that stable line. Now, this is important because of what is called stable vertebra, which again is not important for you because it's a surgical principle. But a vertebra that lies in this stable zone, Basically any curve. So if I'm going to fix this curve as a surgeon, if I start my fusion here and I finish it here, what will happen? This whole building will fall off there, isn't it? That's an engineering principle. So the idea of a stable zone is to know that I have to start my fusion and end my fusion within this zone for the fusion to stay erect. Otherwise, the whole building will collapse. So that's the reason why we draw the stable bone and stable zone and stable vertebra. Not that important, but this is what I'm trying to tell you. Even this is even true for a brace. Just think of it that I'm doing surgery, you're putting a brace. If the brace did not start and finish in the stable zone, the entire column will fall off on one side. And hence, if you want to brace the child, it has to be from the bottom and the top, encompassing the entire curve rather than going halfway into the curve. I think it's a no-brainer here. Is that okay? Any questions? Because we'll quickly move to history taking.
No, sir.
So I just tried to unravel some of the primary definitions in scoliosis. They become important for communication. They become important for a more in-depth understanding of the curve that you're dealing with. And though you may have actually followed only 25% of what I said, I won't blame you for that, because you need a repetitive reinforcement. And I'm more than happy to share this lecture, the PowerPoint, with Snehal madam, so she can share it with you all. And you can reach out to her. Snehal, is that okay with you? I'll just send you a PDF file and you can just distribute it so people can go over this again and again. Because even our postgraduates need to see this talk like 10 times before it actually settles in. So it'll be a worthwhile thing to, go through.
For me, it's a learning.
Yeah, sure. You're the boss. I am learning from you.
We both.
So anyway, I'll pass this on to you and you can just share it with everyone.
Nothing.
So they can ruminate over. So basically, don't feel bad if you've not picked up everything that I'm saying. Even if you picked up 20-30%, it's good for starts. And you see this 3-4 times, then it'll settle in. Now, quickly moving to history taking. See, 70% of scoliosis that you see are AIS, which is adolescent idiopathic scoliosis, which means they have to be an adolescent kid. It can't be a 5-year-old kid. It has to be a kid in the early teens or in the late teens, anywhere between, say, 11 years and so just peripubertal, 11 years to about 17 years. That is AIS. Anything that's outside this line may not classically fit into your commonest form of scoliosis, which is adolescent idiopathic scoliosis. The second word is idiopathic. Idiopathic means we don't know the cause. And no matter what explanation you come up with, what you've read, what you've been taught, today we don't know the cause of AIS. It is not muscle balance. It is not long or short muscle. It's not one leg longer than the other. It is not SI joint dysfunction. It is not pelvic asymmetry. We don't know the cause. All these causes have been checked and it's been found that none of these are contributory. Neither is it genetic nor is it hereditary. Okay, so this is like that dubara mat puchna question, that we don't know the cause of idiopathic scoliosis. So please don't tell your patient that you have scoliosis because there's a 1-inch shortening of your right leg than your left leg. If it's an AIS, that's not true. Okay, there may be another person who has, and there's a way to know it and you'll see it very soon. But your standard AIS forms 70% of all scoliosis that come to you, which is that adolescent girl with a right convex curve. That's the classic scoliosis that will come to you. They have no cause. Okay, so when you take history, you definitely want to know the age. Why do you want to know the age? Because we go back to the etiology. Scoliosis is a growth-related problem. So the more the growth, the more the chance of the curve increasing. So if this child is in the growth phase, so growth phase, as you know, all of us have 2 growth spurts. One is at around age 5 and one is at around age 10. So children in that peripubertal area or in the early age, which we are not actually covering here, the early onset scoliosis, they are more liable to progress, which means that if you see a girl who's say 10 years old and has a 40-degree curve on your assessment, this child, and this child is still tiny and she's just coming close to puberty. About 1 year before puberty and about 2 years after puberty, means after menarche, is when the growth is maximum. So the chance of this 40-degree progressing rapidly is very high. So this child becomes a red flag in your head. You need to monitor her closely. If you say 1 saal ke baad aao, she'll come back with a 70-degree curve. On the other hand, if you see a 17-year-old girl with a 40-degree curve, even wasting 1 year trying to do, physio bracing for her is no problem, because she's not going to progress that rapidly once she's 2-3 years after menarche. Am I getting through? So the age of the patient is very important, which is related to growth spurt, puberty, menarche, which means as a therapist, you need to know what are the signs of puberty. And you can read that up, but there are specific signs of puberty, and menarche is actually before menarche, there are some signs that come up which you need to know, because once it's menarche, you're already halfway into the growth spurt. You already missed half the bus, if you may. You want to know birth history. You want to know if it's there in the brothers or sisters, mainly because if there's a birth history, some problem in birth, there's a chance this is not idiopathic scoliosis, and it could be a neuromuscular CP, etc. What you all see so much. If the brother also has it and sister also has it, once again, it becomes a congenital type of a variety which is runs in family and is probably not an idiopathic scoliosis. You want to know the progress of the curve. So mostly your patient will come to you only when there's been a rapid progress. So invariably they'll say, I noticed this curve at the age of 6, but from 6 to 10 nothing happened. So I was chilling, and then suddenly now it's we feel it's the parents will say we feel it's increasing very rapidly. This is a red flag in your head, because this is the phase where the curve may go out of your hand, and you may have to act on it, act on it quite dutifully and duly. The next is complaints. So the next thing you ask for, like in any patient who comes your way, is what is your complaint? And I've tried to make a rhetoric here, because a scoliosis, an AIS child, idiopathic scoliosis child, has no complaints. The parents complain of a cosmetic deformity. Sometimes the kid is a sharp kid or a conscious kid, like a Bombay girl. They will say, I don't like the way it looks. But typically they are the happiest. They are running around, they play, jump, do anything. They are not affected. But the parents have seen the deformity. So scoliosis does not cause back pain, leg pain, weakness, dysfunction, breathlessness. AIS is a cosmetic deformity. Full stop. Dobara mat puchna. In rare cases where AIS goes beyond 90 degrees, that's when it can cause some respiratory embarrassment. And very rarely in adult scoliosis, all adult scoliosis, which is a different pathology, it's a degenerative scoliosis, will cause you degenerative leg pain and lumbar canal stenosis symptoms. Okay, cervical scoliosis almost not common. Mostly if it's a standalone cervical scoliosis, it's a congenital scoliosis. The standard idiopathic variety of scoliosis is almost never seen standalone in the cervical spine, though a compensatory curve may be going into the neck, where you need to work on balancing the muscle, like making the convex side short and the concave side long through your methods to treat it. But if it's a standalone cervical scoliosis, so if a child comes totally straight but the head is tilted, this is not scoliosis. It's either a torticollis, which is a soft tissue deformity, or there's a hemivertebra there, which is again beyond your purview of treatment. Because of course we still refer them to you to do whatever soft tissue balancing you can, but this does not fall into the category that we're discussing. I hope that's clear, Gagan. So what else? So it's important that the child should not have a complaint. If the child complains of any of this, it becomes a red flag. You want to escalate this to a senior to find out what is the cause of this, because this is not a part of the parcel that should come with you with an idiopathic scoliosis. What you want to ask for is, okay, the parents say that we are unhappy with the cosmesis, but you want to know what part of the cosmesis you're unhappy with. So I'll give you an example. We operated a girl because she said that I'm not happy with the cosmesis. At the end of the day, we got a very straight spine. She was still unhappy. So can you guess what happened? We forgot to ask her why is she unhappy. She was unhappy because her one breast was bigger than the other breast. And this can't be changed by surgical correction. This needs breast augmentation surgery. Okay. Similarly, some people are unhappy because the trapezius fullness. Now, this again is very hard to correct surgically. So you need to know why the patient has come to you, and you need to have a realistic expectation match that, okay, this part I'll be able to correct. I'll give you an example in your parlance. As a physical therapist, you'll probably be able to correct the balance well because of the reasons that we mentioned before, correcting the coronal plane of the lumbar part of the curve. We'll get the balance right. So the child was going off balance, she'll start looking more balanced. And we see that thankfully very often in practice from good therapists like you all, who after a 3-4 month session, the child looks much more balanced. But it's very hard for you to correct the rib hump, because the rib hump is a rotational deformity in the fixed structural thoracic part of the curve, and it's very hard to correct that through physical maneuvers. So when a child comes to you and says that I'm unhappy, you don't promise them rib hump correction. You don't say I will correct your rib hump. Actually, even as surgeons, we tell them not. So what the standard line I say is that my surgery can make you better but not normal. Sir, how much better? Anywhere between 50 and 70% better. but at the cost of two things. One is that there's a whole set of problems that I won't be able to correct. One is rib hump, the other is breast size, the third is trapezius fullness. And at the cost of that, I'm going to give you one big scar in the middle. So similarly, you need to have your disclaimers ready so the expectation mismatch doesn't happen. Again, I'll give you an example of physical therapy. So one of our physical therapists promised the person that she'll make her better, did exercises, the patient was better, gave a brace, and the patient was much better. And in 3 months, the patient disconnected from a physical therapist and went back to where she was. And there was a mismatch in expectations, what the physio said and what the patient understood. So you understand that physical therapy or brace will correct the child as far as it's going on. The minute you stop it, you start going back because the original pathology has not been corrected. Okay, so that kind of has to go through. So I'm just trying to, put myself in your shoes and tell you what are the disclaimers which will make less unhappy patients. Sutapa is asking, in adult post of kyphoscoliosis surgery, there is unbearable pain in the nearby vertebrae. So how can I get rid of it? This is a very different question. It's called adjacent segment. So I'll quickly answer that. See, adult scoliosis is essentially a degenerative scoliosis. It's not this. It's not a scoliosis that happens because of growth. It's a scoliosis where, degeneration of a disc. I think someone has discussed that with you. So the discs start to wear out and the spine starts to shorten. If this wear out happens asymmetrically, just like your shoe wears out on the outer side and the heel will look tilted, just like that, sometimes the discs start to wear out on one side, and that causes the scoliosis, which happens typically in 65, 70-year-old ladies. Why ladies? Because it's one of the big pathologies involved is osteoporosis and sarcopenia, which is more common in ladies. So a 60-year-old lady or a 70-year-old lady comes with a scoliosis, which she says, I did not have as a kid. And the hallmark of the scoliosis is back pain. The next hallmark is claudication or leg pain. This is a different animal. Okay. Now here, as surgeons, our only chance is that we put a rod in and correct this. Okay, fair enough. But at the end of the day, what have we done? We've put in a Ferrari engine in a Fiat car. You understand what I'm saying? The rod makes that part of the spine so much more strong, resilient, and the modulus of elasticity becomes almost zero in that part, while the rest of the spine is a 70-year-old spine, which is dhila. So as the lady starts to walk and load up this flexible structure, this rigid rod fights against the adjacent segments, and there's an accelerated wear out on the adjacent segment called ASD, adjacent segment degeneration, which leads to the pain that you're talking about. And this is an unsolved mystery. The only way to get rid of it is preempt it. So when I do this operation, I tell them, I'm just going to correct this part of your spine, but remember the rest of your spine is a Fiat car. And we need that Fiat car to convert into a Ferrari car to be able to match with this Ferrari engine I'm putting in, which means that lifelong, aggressive, structured physical therapy to get the muscles into shape, to balance or to support this weak dhila spine is your only bet. So all adult scoliosis patients after surgery get lifelong physical therapy and lifelong osteoporosis therapy. Is that clear? Sudapa?
Yes, sir.
Yeah.
Thank you. Yes, sir. Thank you.
Sudapa?
Sorry?
Is that your first name?
Yes, Sutapa. First name.
Nice.
Okay.
Okay. So what else? Any other questions? You can just unmute and ask. This is the important part, which, is not surgical. See, these are the things that you want to look at. It's a whole bunch of things out there, and you can't miss any of these. You got to look at neck tilt. You got to look at trapezius fullness. That is how full this looks compared to that. You got to undress the child properly. Here, she's not undressed properly. You got to look at shoulder height, which is the lateral shoulder height and the medial shoulder height. So you got to see how this matches with that and how this matches with this. You got to look at the chest cage deformity. Where is the hump? Where is the depression? You got to look at the arm trunk distance. All these are abnormalities that you will see and the child will notice, and you got to ask what they notice. You got to look at truncal shift. So how is the thoracic cage in comparison to the pelvic girdle? Is it shifted off or is it in the middle? What is the angle? So here you see the thoracic cage is in that axis while the pelvic girdle is in this axis. So all these you need to know. You got to look for flank creases, which is the counterpart of, opposite of a rib hump in the lumbar spine. You got to look at how the limbs look. Is there a limb length? I mean, is one knee being kept flexed? You know the reason why. And then you got to check neurology because it has to be normal in your idiopathic scoliosis. Now you got to check these children in the sitting, standing, and in the lying down position. Okay, now can someone tell me, Rucha, can you tell me if this child has a scoliosis when I see her? Okay, I'm just flying through this. But the minute she sits up on a, on a bench, the scoliosis disappears. What does that tell me, Rucha? Anyone else? Mitali? So
Functional
basically,
scoliosis.
yeah, say that again.
Functional scoliosis.
It's functional.
No. Well, I'll repeat my question. The child is standing in front of you and the spine looks bent. Okay, the minute the child sits in front of you, so she's sitting on a couch and you're looking at her from behind, the spine has corrected itself. What do you think the cause is?
So maybe the reason is that below the pelvis because she's
Pelvis.
compensated.
Totally right. You get a chocolate for that. It's limb length discrepancy. The minute you've taken the legs out of the equation, the spine corrects itself. So limb length discrepancy takes away the scoliosis as soon as the legs are out of the equation, which means sitting. So you have to examine every child in the standing and in the sitting position. Okay, now second question, which is a gold medal question, that on standing there's a scoliosis, on sitting also there's a scoliosis, but you make the child lie down and the scoliosis starts to disappear. What do you think is the cause? Anyone?
So it is muscular weakness.
Absolutely, you get gold medal. Who said that?
Vishaka.
Vishaka, gold medal. Snehal, Lakshat Thev. You got to give her the gold medal. Because a spasm, that scoliosis, that's because of a muscle spasm, which is a painful muscle spasm. We call that a list. Disappears when the patient is offloaded and the muscles relax. And that can differentiate spasmodic scoliosis, or someone called it a functional scoliosis, compared to a structural scoliosis. I hope that's clear. Okay. So all your children, examine them in the, of course, standing position, flexion, extension, lateral flexion, lateral bending, suspend and see how much the correction is. So you can suspend holding under the arms, like in the armpits, and lift the child up, or we normally hold them here. So all three curves get corrected. You examine them in the sitting, lying down position. You examine the gait, because sometimes gait will tell you a neurological deformity, a hip problem, or a knee joint problem. So we normally look at gait from that perspective. Do you all know the difference between a lurch, an antalgic gait, and a short limb gait?
Yes, sir.
Yeah. So and examine the spine neurologically. Again, Manjot asks, what is the importance of a forward bending test? So forward bending will exaggerate the rotation of the scoliosis. When you bend forward, the rotation becomes more, which means the rib hump becomes more prominent. Now, this test is important for screening of kids. So sometimes, because most of us are trained to identify scoliosis by a rib hump. If there's a subtle curve but no rib hump, you sometimes don't clinically identify it, especially if the child is wearing a t-shirt, right? So when you're doing a school screening, for example, where you can't strip every child and examine them the way you examine in the clinic, and you don't even know who has a scoliosis, the minute you bend forward, if you find one rib hump is getting exaggerated, which means a subtle rib hump becomes an obvious rib hump, you take the child out and say, okay, this guy has scoliosis, I need to examine him better. That's all. So bending or a forward bending test only exaggerates or accentuates an apical rib hump, and it makes a subtle scoliosis more obvious. Okay, so it's not that important in a clinical specialty practice like ours. Though we all do it, it's not that important. Okay. Now, this you need to know, that if any of these are seen, your child has a very high chance of rapid progression. So one is, of course, we discuss younger the patient, more growth left means more chance of progression. Reserve grading. So does anyone know what is a reserve grade? So invariably, when we do X-rays for scoliosis, we also include the pelvis, and I'm just going to pull out an X-ray to show you what I meant. So any X-ray of scoliosis, maybe this one. No, this one doesn't show. So it's a badly done X-ray. But sorry, I'm just flying back to show you some X-ray. Look at this. So any X-ray should show you the ilium, and the ilium has a topi on top of it. It's like a cap on top, which is the iliac apophysis. If you look hard, you'll see a part of that topi here. This apophysis starts forming on the outside, then comes here, and then finally it fuses. So reserve grading is actually how much of this apophysis is present because it depicts how much growth is remaining. So there's reserve 1, 2, 3, 4, 5. Okay, so if it's a low reserve grade, which means that topi is not seen, the chance of growth, more growth is very high, and hence these children, these children become red flags. Females have a higher propensity of progression. If there's a family history, higher chance of progression. If at presentation the Cobb angle or the angle is 20 degrees or more, higher chance of progression. More rotation, more chance of progression. Double major curves, and don't leave alone this RVAD. It's a very technical thing. It's rib vertebral angle difference, which is a technical thing that we see, the angle between the vertebral body and the rib on the left versus the right. If that difference is more than 20 degrees, it means that there's a high risk of progression. The only importance for you and me is that this angle was discovered or noted by an Indian-based lady surgeon in UK called Min Mehta. And that made her world famous. It's called Mehta's RVAD. So in the 60s, she gave this information to the world that if the angle between the rib and the bone, on the convex side versus minus the concave side, if the difference is more than 20 degrees, the chance that this is going to progress rapidly is high. And it's India's contribution to early scoliosis, though she was a British Parsi Indian. Okay. So I told you 3 foot, that's 36-inch standing films is what you need. Look at every curve in 3 parts, and always look at the lateral X-ray for the true balance on the lateral film. Look at the coronal balance, identify the curve when you see the X-ray, identify which are the likely end vertebrae, the most tilted vertebrae on either end of the curve. Yeah, we should break this into one more part. Yeah, sure. So I think this is a lot of information at this point. So I'll actually conclude here, and but I'll just this is that Risser sign, that Risser angle, the Risser sign that I was saying. This is that topi that you have to look on the ilium. That's the ilium, and that's the topi of the ilium. If you divide this into 4 parts, you have Risser 1, Risser 2. This is the time when growth is still happening. Once you cross the Risser 2, the growth spurt is over. So a child in whom you see this cap beyond the halfway has actually gone past the maximum growth phase. So if you see our growth, it happens as a bell curve. It doesn't happen linearly. There's a slow and there's a zoop. That zoop part happens in this Risser 1, Risser 2 phase. And that's when scoliosis can get worse rapidly. We spoke of the neutral vertebra in terms of rotation. I'm going to pause here for a minute and discuss how to go forwards. We spoke of the stable zone. This is just revision. We spoke of bending X-rays, convex bending and concave bending. Remember, they are convex and concave for one curve. So a convex bending for one curve could be the concave bending for another curve. And you got to appreciate that. You will appreciate that the minute you start looking even at a straightforward scoliosis like this as a third curve there. So you got to say that this is 1 curve, 2 curve, and 3 curves. You can get a traction film to, especially in paralytic scoliosis, traction films are important. So all the neuromuscular kids you get. So you all treat a lot of neuromusculars, as I understand, all the, CPs, etc. Traction X-rays become more important. And of course, look at pelvic obliquity. There's a classic CP. We are not covering that here. And this is how finally you will give a diagnosis to, this is how you finally give your diagnosis. So we'll pause here. We can even halt here. And Snehal, what do you feel? Should we stop here? Should we take questions or?
Yeah, we can take questions and we can get together next Saturday again to the Salata Center.
So I understand this is very heavy, but did it did anything, even if 20-30% goes in, no? And then you can review this or, go through this again on the lecture that I give you, that I'll share with you. It will make sense. Actually, a second part is not needed because the next part is about treatment, which is mainly surgery.
That is important.
Okay.
Yeah. I think that.
Yeah, so we can do it, but I'm just saying.
You have time when it's up to you.
No, I'm free all the time. I'm actually, if you all are enthusiastic, I'm very enthusiastic. That's the.
Very much.
So anyone, any thing that went totally over your head, it's a good time to ask. But I didn't overdo it. Whatever I told you is what I expect all my scoliosis therapists to know. And I can assure you that most of the people who, we refer for scoliosis, there are some yoga instructors also, I must tell you, who are very knowledgeable in this. And once you know this, it becomes easy for me to refer to you. Because no matter what, very few kids on first presentation go in for surgery. First presentation is always counseling. You explain just the way I explained you. Make them understand, what went, what's the problem, and first put them to physical therapy. Now, there's a one-line answer as to what a physiotherapist can do, and this answer resonates. My feeling about a physiotherapist is that in your body, everything gets worse. Bones get worse, joints get worse, ligaments get worse, cartilage gets worse, nerves get worse, but muscles in your musculoskeletal system are the only regeneratable tissue that you have available to you, which you can spice up even at 90 years of age, albeit slowly. And hence, when we send any problem to a physical therapist, we expect the physical therapist to build up muscles to compensate for the weak bone, joint, cartilage, whatever else. So the job of a good therapist is to build up the right muscles to take the load off, or to correct or to balance the badly structured or the badly worn out skeleton. So I think that sums up what we expect from you.
That's great.
Okay.
So next Saturday, Nakki.
We'll figure out when.
Sir, thank you. Sorry. Thank you so much for the talk, sir. I just wanted a little more clarity from you when you said about the compensated curve, that physios won't be able to help much in the compensated curve, but decompensated they can bring to compensated.
Yeah.
So
think about this, that a compensated curve is an S. It's a perfect S, like a dollar sign. So the balance is straight. So if you want to correct this dollar sign, how do you think you will correct it? You will stretch it out, right? That's the only way to correct it. Stretching out, it becomes very difficult for muscles to do. Muscles have a limited role to stretch your vertebral column upar niche, which surgery can do quite well because you're anchoring and pulling. On the other hand, a decompensated curve is like a lazy S. There, muscles can definitely bring the center back because there's one lengthened side, one shortened side. If you shorten the lengthened side and lengthen the shortened side, you can get that balance back. So the role of physical therapy to get an obvious correction, though all patients are sent to physiotherapists, a good patient satisfaction will come in a decompensated curve because they will start compensating, and we see that all the time in practice.
Right, sir. So where I'm coming from, I was thinking like if even in a compensated curve, if we are working more on the primary curve and trying to like we can't correct as such primary, but at least secondary curves we can keep on working on, so that even post surgery the therapy is easier, like coming out of.
You nailed it. That if there's a compensated curve, which is a typical situation post-op, right? Post-op, we've compensated them, but we still send them to physical therapists because you want the base to be very strong. The abdominal is the trunk. So how would you, give me traction? You'll pull my stomach in, right? That's how I'm becoming tall. From here, this is what I need to do. So we need you to build all the lower trunk muscles up to be able to hold the whole pillar on top and balance it. And that's what you do in a compensated curve with or without an operation. Totally.
Right. Okay. Thank you so much, sir.
Okay.
Thank you.
We can keep some case discussions next time. The ones
okay. I'll try and pull out cases which we have treated with therapy rather than surgery.
Also, I would suggest that, to add on to the examination part, the atrophy or the hemiatrophy, if it is there, that is something which we look at.
Congenital scoliosis.
If there is any problem with the circumference.
Hemivertebra. Is that what you're saying? Hemivertebra?
Yeah.
Okay.
That's
Cool.
it.
Okay. Superb. This is the best Saturday evening with so many pretty girls. Like a multiple date for me, okay? Okay, thank you again. Cheers.
See you.
Bye. Thank you, Sneh.
Thank you, sir.
Bye.
Thank you, sir.
Thank you.
Mika and Arya, wait, please.
Waiting, ma'am.
found the